हाँ, ठीक है यार, ये थोड़ा अच्छा वाला ही था। मैं डिस्कशन किया तो अगर वो होते तो अच्छा होता। So, good morning, everyone. Uh, I'll be as given in the academic schedule. This was supposed to be a class on erectile dysfunction. So what I'll do, I'll actually go through a case of erectile dysfunction, and basically mostly we'd focus on the history taking part. So that how sexual history is somewhat different than other history takings. Maybe some additions are there. Then we'll go through that and we'll maybe discuss the importance of such things. Okay, what why these history has to be taken. Okay, then we'll maybe some, if you guys want, we can have a certain small discussion over the pathophysiology of it, right? So Dr. Shovidhar is my moderator, Shovidhar sir, and I'll be, actually I had presented this previously. I presented it previously in my academics. So Mr. B, a 35-year-old male, married, belongs to the Hindu nuclear family from Hisar in Haryana, and he's a BSc in nursing and is currently a nursing officer. Patient has been seen alone, but the information seems reliable and adequate currently. The chief complaints were decrease in achieving adequate penile tumescence during sexual intercourse for the last 1.5 years, and delayed initiation of sleep for the last 1.5 to 2 years. So the onset has been insidious and has been continuous in nature with a progressively worsening course. No predisposing, precipitating, or perpetuating factors could be identified currently. Coming to the history of present illness, patient was apparently all right 1.5 years back when he was working as a nursing officer at a hospital in his hometown. Actually, he was from Haryana, but he was working in Rajasthan. He was married since 2014, which was an arranged marriage, and had cordial relationship with his wife. They have a child of 5 to 6 years of age. He used to have satisfactory sexual contact with his wife till about 1.5 years. The couple would enjoy penetrative intercourse about 4 to 5 times in a week. This was the pre-morbid thing that I am going through. The duration of sexual intimacy would last anywhere between 30 minutes to 90 minutes. There would be no problems in finding time and place for sexual intimacy. The patient reports normal morning erection about 6 days per week before the onset of complaints. The patient used to masturbate only when his wife would be away for 7 to 10 days, maybe in her own home. The strength of erection of the same would be adequate. The patient's sexual fantasies were in keeping with that of a heterosexual man. He used to have such fantasies with other women before marriage and with his wife and other women after marriage. Spontaneous erections would be 3 to 4 times per day, would be mostly associated with sexual fantasies or visuals, and quality of such erections would be average to strong. So these are the things that you need to take in the history: spontaneous erections, sexual fantasies, all these things come in sexual history. The patient states that there has been a loss of completeness of erection during sexual intercourse, which started out 1.5 years ago. He describes that the penis would remain soft and limp and would not become that hard as before during sexual intercourse. He reports that he would face difficulty inserting the soft penis inside the vagina, and that either he or his wife had to guide and support the penis inside with their hands. He would also face difficulty in the pelvic thrust during penetrative intercourse, as he would feel a loss of grip inside the vagina. Initially, he would have such problems for 2 to 3 times per week and have normal erection the other days. Gradually, he reports that due to dissatisfaction in erection, he did not have desire to perform penetrative intercourse in the initial frequency, and in the next 5 to 6 months, it reduced to only 2 to 3 times per week, which was 5 to 6 times per week. It reduced to 2 to 3 times per week, secondary to this perceived loss of adequacy of erection. The strength of his erection had come down to only 40 to 60% of the previous on most days, with occasional about 80% erection strength 3 to 4 times per month. So occasionally he would get about 80%, but generally he would get 40 to 60% of the previous set. His frequency of morning erection too diminished to about 3 to 4 days in a week. Most of the aspects of spontaneous erections diminished too gradually. So body erection came down, spontaneous erections also came down. The strength of erection in masturbation also diminished to about 50 to 60%. Not that only in penetrative intercourse it diminished. In masturbation also it diminished to about 50 to 60%, which he seldom used to do anyways, and only his wife was there. Episodes of continuous nocturnal emissions relatively increased during this period of perceived sexual dysfunction, from 2 to 3 times a year previously to around 1 to 2 times per month at present. So around 12 to 15 times per year. It has increased. This gradual and almost persistent decline in most of his perceived sexual capabilities led to a relative decrease in desire to have sexual intercourse. Just around this time, he got the job of a nursing officer in AIIMS Rishikesh and thus had to shift to Uttarakhand province. After coming to Uttarakhand, the problems did not abate and kept on declining gradually. He would visit his home once in a month for 4 to 5 days, the first 1 to 2 days of which he would have 80 to 100% erection strength while having intercourse, after which it would decline to 30 to 50% in the subsequent days. So every day he wanted to have intercourse, but in the 5 days, and in the 1 or 2 days, it would be 80 to 100%, but after that, it would be only 30 to 50%. According to him, the wife corroborates with his complaints. The patient had an usual sleeping schedule of bedtime of 10 p.m., wake time of 7 a.m. This was the premorbid thing. Subjective sleep onset latency was 15 to 30 minutes. Did not have any significant changes. Did not have any significant changes on night shifts to impair daily sleep schedule. Usually felt fresh in the morning after waking. Around 2 years back, he started spending more time in bed after lying down to sleep. It ranged anywhere between 30 minutes to 1 hour to fall asleep. So it had increased the time spent in bed to fall asleep. He would not fall asleep as easily as he would previously. He reported restlessness in the lower limbs when he would lie down or sleep. He specifically used to feel this sensation in the muscles of lower limb, as if something was crawling inside the muscles. He would feel significant relief if he moved or banged his legs against the edge of the bed. He would sometimes have to get up from the bed and walk around for 2 minutes. Thus, the time to onset of sleep gradually increased to about 90 minutes. The frequency of such disturbed night sleep gradually increased from 1 to 2 nights per week in the first year to 5 to 6 nights per week in the last 5 to 6 months. These sensations could not be present in any other body parts, and it would also not be present during daytime or periods of sleep. There would be no alteration in the intensity of lower limb restlessness with the amount of physical exertion done throughout the day. So whether he had more physical exertion throughout the day or he had rest throughout the day, these sensations would be there in the night. Coupled with these two types of problems, the patient came to psychiatric OPD for consultation. Going through the negative history. So no history suggestive of any trauma to the genitalia, no history suggestive of consumption of any substance known to cause such rapid deterioration of penile tumescence, no history suggestive of any local lesions or known deformity of the external genitalia, no history suggestive of any spinal trauma, no history suggestive of persistent pervasive low mood, no history suggestive of sexual dysfunction confined only to the wife, no history suggestive of panic episode, specific phobia, or clipboarding anxiety, no history suggestive of repetitive, intrusive, senseless, and ego-dystonic thoughts, images, doubts, or tips. No history suggestive of substance use in dependent pattern, no history suggestive of any shift worker disorder, no history suggestive of excessive snoring, choking spells during sleep, increased nocturnal nutrition, excessive daytime somnolence, no history suggestive of decreasing limb restlessness during holidays. So whenever he was inactive, that time the restlessness would decrease, that was not there. Okay, so it was always consistent. Now, coming to the past history, no history suggestive of any anemia, multiple sclerosis, diabetes, hypertension, varicose veins, general disorders. So I'm ruling out most of the physical disorders which might lead to such erectile problems or restlessness legs. No history suggestive of any cardiac disorder, dyslipidemia, no history suggestive of thyroid disorder, no history suggestive of neuropathy or myopathy, no history suggestive of similar complaints in the past. Treatment history, this is the first consultation for the specific complaints. No faith healing or alternative medicines have been tried by the patient. Coming to the family history. So as you can see from there is a huge family on both father's and mother's side. And there was, he's the youngest of 3 siblings, one elder brother and elder sister. And mother had symptoms suggestive of RLS, no history suggestive of similar or other psychiatric illness in the family. Father was the primary decision maker in the family, whereas responsibilities and duties were divided among the members. Authoritative parenting style was used. No discussion of any sexual related topics within the siblings also. Family of this was the family of orientation and family of procreation. Married in 2014, as I said, arranged non-consanguineous marriage with further history. Later on, we will discuss. Couple has 1 male child. Personal history, birth and developmental, nothing. Childhood history, again, no typical adverse events, no history suggestive of abuse in childhood, no history suggestive of any child labor. Scholastic history, average to good in studies, nothing significant contributory. Vocational history, started working as nursing in a nursing home in 2012 and changed job twice in the next 8 years. for better salary, and no history suggestive of any workplace distress, and ultimately secured a job in AIMS education in 2020. No significant workplace alterations or termination of job. Now, coming to sexual history, this will be a bit long in this case. In addition to the above mentioned history of present illness which we have described, the patient had almost no discussion of sexual practice in childhood at home, no accidental or unusual sexual experiences in childhood. Premarital history, if we go to, started masturbation at the age of 13 to 14 years of age, 2 to 3 times per month, experienced adequate erection strength associated with fantasy or visual stimulation. Age at first intercourse was 21 years. Premaritally had sexual intercourse with 2 women, one married and the other unmarried, had around 50 to 60 times intercourse before marriage. No such problem experienced any time as experiencing now. He had arranged marriage in the mid of 2014, that after which there was a regular satisfactory sexual life with her. After the wife conceived by the end of 2014, he became involved in almost regular sexual intercourse with one of his female married colleagues, which continued for the next 2 to 3 years. He describes her to be the most proactive partner among all his sexual partners. He used to enjoy the act most with her, to the extent that he would not have any desire to perform the sexual act with his wife, which he anyways was avoiding because of the ongoing pregnancy at that time. There was a significant period of deterioration in interpersonal relationships between the couple in 2015-16, when she got to know about the extramarital affair. There was almost nil sexual intimacy between the couple for 5 to 6 months. However, IP relations improved over time with the intervention from elders in the joint family settings. The patient, however, continued his almost regular sexual intercourse with the female colleague without the knowledge of his wife for the next few months, until she was transferred elsewhere. In the meantime, after this, sexual relationship with the wife improved to such satisfactory levels compared to the extramarital after the extramarital one was gone. In the last 2 years, there has been no sexual intimacy with the female colleague. After he has come to Rishikesh, there were 2 instances of sexual intercourse outside marriage in which he faced almost similar erectile problems as with his wife, as the 50 to 60% strength problem. Household and business responsibilities are taken care of. This is the marital history. Household and business responsibilities take care of the wife. Patient reports no IPR issues currently, and that there is a good understanding between the two. Wife looks after most of the duties towards the child. However, decisions pertaining to the child are taken by. Now, going to a bit of detailed sexual history. Foreplay. The patient used to spend time in foreplay about 5 to 75 minutes in range. Duration with partners other than wife has been greater than 20 minutes. With wife, it has decreased. It used to be similar, but however, decreased in the last 2 to 3 years. It remains around 5 to 10, 15, 20 minutes when he goes home once in a while. Foreplay would consist mostly of kissing, smooching, fondling, various body parts, cunnilingus, and fellowship. He reports equal enjoyment and satisfaction in different modes of foreplay and penetrative intercourse. He also reports that the foreplay was the most satisfying with his female colleague and that she used to be the more proactive one. Coital position, where mostly 2 coital positions were used by the patient, the missionary and the female superior. Female superior was mostly performed with the female colleague, not with other partners, who herself preferred that, and all other missionary positions were, with all other missionary positions were more preferred. Patient himself did not have a specific preference. He enjoyed by whichever position the partner seemed satisfied. None of the partners needed excess persuasion for sexual act. All were cooperative and easily agreeable. No coldness, frigidity, passiveness, aversion was complained by the patient with respect to any of the partners. Sexual sensations responsive to most of the sensory stimuli. However, patient reports most arousing to be the visual sexual stimuli rather than auditory and olfactory. Attributes attractive were vagina and lips for the wife, breast and lips for the female colleagues. Attributes unattractive could not report any attributes of the partner which would really turn in. Pre-marriage personality was generally well adjusted. General physical examination, nothing grossly abnormal. Local examination of the external genitalia did not reveal any gross abnormality. His BMI was well within normal limits. Secondary sexual characters were adequate according to the male pattern. Systemic examination, again, nothing gross, nothing abnormal. Most of the CNS examinations were also within normal limits. The mental stress examination patient came to the OPD alone, greeted the examiner, sat unsupported on the chair, proper dressing and grooming, spontaneous initiation conversation, replying relevant questions, eye-to-eye contact with initiated and maintained, rep was established. Speech was all within normal limits, spontaneous prosodic, relevant coherent, normal response time, mood and affect, distressed, range and reactivity, within normal limits, appropriate and congruent, no liability. Thought, no abnormalities in form stream position, contains suggestive of distress regarding sexual problems and apprehensions about conjugal life ahead. Perception, again, nothing. Cognitive function testing, attention, concentration, or orientation all within normal limits, memory, arithmetic, general fund of knowledge, all according to socio-educational background, abstraction and judgment, no gross abnormality. So if you go to the diagnostic formulation, would result in a 35-year-old married male from Haryana currently working as a nursing officer in MCK with nil contributory past history, marital history, suggestive of dysfunction previously, and well-adjusted female personality, has presented with gradually worsening symptoms of restlessness in legs during inactivity or lying down, partially relieved by movement for the last 2 years, and progressively worsening decrease in penile tumescence, resulting in difficulty in performing sexual intercourse for the last 1.5 years. On examination, gross physical examination was within normal limits, and MSc suggested distress mostly regarding sexual problems with some distress regarding sleep problems. And the CFT was cognitive function testing was within normal limits. My provisional diagnosis at that point of time was restless leg syndrome with query erectile disorder. Before discussion of this case, it was within a query whether erectile disorder was present or not. So, sir, I would actually like to get your inputs regarding whatever history I have spoken about, that what might be, whether it is a erectile disorder or not. So maybe you can ask questions. After that, I'll go to the management. Anything, any doubts in history or anything unusual that you find in history?
This problem is that
yes, sir. So this after in the last 1.5 years that he has been reporting the problem, he has had problems with both his wife and in the extramarital. Actually, 3 or 4 instances on the extramarital intercourses he reported in the last 1.5 years, and he had problem in. But there were some instances when he used to go back to his wife after about a month, because he was staying in a separate place, and he would go back in holidays. Every month he would go, and whenever he used to go back to his wife, in the 1 or 2 days, first 1 or 2 nights, it would be good, but then again it would decrease, which was not the case before 1.5 years.
Oh. Problem in, say, erection, that he is unable to perform. Or it is just like he said, 50%.
Yeah, so sir, what he says is that compared to the previous self, what he used to have, he says that around 40 to 60% erection is remaining in varying degrees in most of the intercourse he performed, and he feels that there is a loss of grip in the vagina, and maybe he needs his hand to guide the penis into the vagina, so it is not so hard that he can easily enter. These are the problems he is able to perform. Sir, actually, the thing is that although I could not, the major drawback of this case was that I could not get the input of the wife. So, but the thing is that he says that it is so distressing for the patient that he quits performing. He just takes out his penis and goes to sleep. That he doesn't have the grip and he can't. His pelvic thrust are of no use. So, in that sense, he goes back. It is not that the ejaculation happens. Ejaculation, there is no problem of premature ejaculation.
Apart from that, morning erection.
Morning erection has decreased, sir. Spontaneous erections have also decreased about 30 to 40%, and what will I say, strength of erection in masturbation also has decreased.
You haven't done any investigation.
No, sir. That is what I'll come in the management part. So yeah. So before going on to the management, so the history still remains to be clarified in details from the wife. Actually, after this, I tried following him up for 1 or 2 times. He came, but then again, he did not let us communicate with the wife. Corroboration, wife's perspective about the perceived problems, everything had remained. Routine blood investigation, including CBC, LFT, KFT, thyroid profile, lipid profile, the blood sugar, everything was within normal limits. The HbA1c all within normal limits. Scales applied on first visit for IRLS for the restless leg syndrome, and the International Index of Erectile Function for domain A for the erectile dysfunction. So 20 out of 30 actually gives a mild to moderate. According to the score, it is a mild to moderate dysfunction. Tablet propionyl was started because of the RLS symptoms, and education regarding further clarification of sexuality. This was the first visit. History and subsequent planning of management were were performed. On the second visit, patient reported around 70% improvement in the sleep and ILS symptoms because of the propylidol. IRLS had come down to 9 from 26, so significant improvement was there. In this time, the patient had gone home for 4 to 5 days in between, when he had adequate erection for the first 2 nights. Then it gradually decreased to 50% in the next two days. The sexual satisfaction also was better than the initial day, as he was reporting earlier. Okay, so there was no significant improvement in the sexual function. Now, the next one, this was written by me when only 2 visits had come. So we had discussed whether clarification corroboration obviously was important. A urology consultation was pending. Now, should we proceed for any investigations like hormonal panel and penile Doppler? The discussion was yes, we have to proceed for hormonal panel and penile Doppler, which would be available. Now, generally speaking, in this case, what we were supposing it is because of the RLS, maybe because of the sleep problems which had started around 3 to 4 months before the erectile problems. So whether this was interfering, whether the loss of sleep was interfering in erectile function, that was one thing that needed to be ruled out. But since with the improvement of sleep problems also, he did not report any significant improvement in the erectile function, we planned later and gave PDE5 inhibitors. With that, there was around 70% improvement in SOS basis only, not in every intercourse, but in 70% 70% of the frequency he used to have those, and it was resulting in much better improvement than what it was now. Now, sir, penile Doppler, he actually refused to undergo penile Doppler because of the fact that when we counseled him about this injection which had to be given before the Doppler, and the side effects was very less, but maybe because of his because he was a nursing officer himself, he backed out from. He did not undergo a penile Doppler. Hormonal panel he underwent, but then hormonal panel was within normal. So penile Doppler, what we suspect, maybe we could have found some arterial insufficiency or venous, I don't know, maybe, but arterial insufficiency maybe we could have found out. Although there are no such predisposing factors that would lead to such. He was not having any cardiovascular disorder. He was not having any dyslipidemia. But then again, this penile Doppler was elusive. One more thing is that what we found out in our discussion is that the expectation modeling, expectation moderation. What was his expectation? Every night he has to perform, and every night he has to get this adequate strength of erection. That is something which is a very high expectation from his aging self. He was 35 to 40, but the thing is, he was active since 20. Now, every time he would get that, it is according to our discussion, it was not very proper expectation. So every night he would have to get that. Now, that was one thing which was also in our minds while counseling the patient. But then again, penile Doppler, because we found something in the PDE5 inhibitors, some improvement, but then penile Doppler was still elusive. So my take on this case was, first of all, it is very difficult when you don't have corroboration. It is very difficult. Maybe he's just speaking that okay, I'm not getting erection. The wife will no, he gets erection. It is adequate for the sexual intimacy. I had similar such patients. Patient came with almost similar problems. Called the wife. 2 weeks after the wife came, he was having a depressive cognition with psychotic disorder. Total psychosis and depression was there, and he improved totally with these things. And he is having no sexual dysfunction. Wife told he's totally having this infidelity ideas, and that's why he says that he is not improving. He's performing more, I will tell. So now wife's corroboration was very much required on this. But since he was working in our institute, we had to believe him to some extent. We could not let him go, but clarification was required, I would say.
Is it possible that sometimes there is 90% and other times
this was very doubtful, that whether it was happening or whether it was his perceived thing. But then again, if the low dose tadalafil is 5 mg was given, actually Rao sir had advised me to give this. This was presented in the forum of sexual fellowship. So he had advised me to give this. Sometimes there is some increment in this, and with that increment, patient perceives their sexual model to be very much efficient. So maybe
My
that
question
was
is it possible theoretically that a patient with
no, ma'am. Generally not.
insufficiency will have 90%
Generally not that it will be possible in the few instances, like 20-30% instance they will have erection so much and they will not, generally not. But I have not gone too deep into this, but venous insufficiency, sometimes the venous return is very high. Sometimes it is possible that the venous return remains normal and there is good erection, a good erection. Now generally we were stumbling somewhere between psychological cause and this thing. Now the main thing was that in DSM-5, they have written that 75 to 100% of the times you have to have this problem. Now, his was around 80% of the time he was having this problem. So he came into that category. Sometimes he was having good erection, but 80% of the time he was not having, according to him. So that's why that's why I had the query in the erectile disorder. But after discussion, it was suggested that this was an erectile disorder. Erectile dysfunction name is not there in DSM, it is erectile disorder. So but then we tried both. But with his resistance towards a penile Doppler, it was very difficult. Had the penile Doppler been done, it would be very objective. The findings would have been very objective. So regarding the pathophysiology, if I can mention that it happens due to various causes. It is mostly like arteriogenic, venogenic, neurogenic, endocrinogenic, and there is one more cause, drug induced. Okay, so in the arterial causes, again, the elasticity of the arteries, everything matters. The venous cause, similar things. The other disorders of cardiovascular system, they lead to certain such inelasticity. In the neurogenic causes, due to the central control of the medial preoptic nucleus, there are actually two types of erection. One is reflexogenic erection, when we stimulate the penis from outside, then there's a reflex erection without the central control, and one is central erection through the visual and other stimuli which we have from the medial preoptic nucleus. So if any of these get disturbed in spinal trauma, often the reflexogenic gets disturbed. Often it is preserved if the level is above. Okay, so the spinal pathway is preserved. So reflexogenic erection is there. Now any of these is disturbed, the neural control is lost. Okay. Then endocrinogenic, we have so many hormones which influence the erection, be it from testosterone to prolactin to dopamine. Everyone has a role in this erection part. So even if they are disturbed, it decreases. And drug induced, most of the incriminating drugs, commonly incriminating drugs are thiazide diuretics and other diuretics also. Some beta blockers. These sometimes hamper erectile functions to some extent, to much extent.
Are you saying that he has erectile disorder? What is your?
Sir, my opinion is that he has erectile disorder. The psychogenic versus the medical cause is still that's where I am confused. He has erectile disorder according to him. Now we have to go with his history now. According to him, he has erectile disorder. But whether
for operation to right?
No, that is even over the phone we try. Yes, sir. That is one. There is actually 12 types of tests for this penile function, sir. Nocturnal penile tumescence test. You previously was a very go-to test for the patients. They used to place a paper, and if the paper would in the morning it would be found torn, so it was with the lumen of the flaccid pins, and if you torn, then we will find that this erection is there. And nowadays it is done with PSG, combined with PSG. Now the thing is that it reflects more on the REM sleep part of with the REM, whatever erection is there, it reflects more of that sleep-related erections. Now, whenever sleep-related erections are there, we find that the organic cause is maybe not there. Even with morning erections, we have this. The organic cause may not be there. It's mostly psychological. But then again, he was reporting morning erection. We did not do the nocturnal penile tumescence test with PSG as mentioned. Although we had a PSG, we could not do that. But there are other tests also: penile plethysmography, cavernosometry, cavernosography. Your penile Doppler obviously is there. arteriography is there. So all these tests could have been done, but the most common was vinyl, which he refused. Urinary concerns was done. They also prescribed adrenaline. They usually prescribe adrenaline for it. They don't go into the psychological part.
This was mainly on his part.
On his part, sir. Yes.
What about say for his libido, so that he has to perform daily?
His libido was totally unaffected.
That he has to like in the history also.
Hmm.
And his wife was pregnant, unable to found another
Yes.
partner.
Yes. Yes.
So, what effect did it have if he was not, say,
Yes.
having performed? He did not have the opportunity to be distressed and
Yes, sir.
was he worried?
Totally, sir.
Did he have any symptoms? Because of that?
I would like to concentrate on that. I had told in the present history also, sir. He when he was not having this thing in the last 1.5 years, when he was in Haryana, when he was not here in AIMS, he was in AIMS only for 1 year. Before that, he was in Haryana. So when the problem started initially, and he had no extramarital partner at that point of time, I had discussed that after 1 or 2 months of this perceived inadequacy, he actually decreased his frequency of intercourse. So he was thinking, okay, this is not working. So why the hell should I have intercourse? It is not worth it. Now he was having this distress. Someone who has such a good perceived performance cognition, he supposes that okay, I am not able to perform on maybe 70% of the time, 80% of the time, I will not do intercourse. Now this leads to distress. Often, what sir is saying, often these are the symptoms which might lead to some depressive cognitions also. But
I want to see whether he has some kind of compulsive, he has a compulsion to perform sexual activity, not sexual addiction.
No, I understand.
Because, from the history, he had 2 partners before marriage. During marriage also his partner. After having
Yes,
difficulty in his relationship, again he had partner. And his whole object towards his partner is towards, you can say, physical relationship, okay, emotional relationship. For example, I would like to know if that colleague that he had one year relationship was purely like they were, or there was some emotional connect also.
Sir, it was 80% physical. Whatever conversation I had with the patient, it was 80% physical because they used to have it like on in the night shifts and everything. But the thing is that an emotional connect was still missing. He had never planned to settle with that person, or maybe he had never planned to leave his wife. He has always been with his wife, but then again, he had never had this emotional what will I say, emotional softness toward that person. That I could not find.
This thing was with a belief.
Hmm.
Okay, at the job site, putting his job at this, putting his,
Yes.
The married colleague.
He's a married person. Definitely, she was a married
putting
person.
his marital life at risk for sexual activity.
Yes.
Risk-taking behavior to
There
to
is
procure physical distance. That is one thing that I wish to know whether he has some compulsion, some or maybe addiction where he has to perform
yes.
coitus, and because there is this high libido, maybe
Yes.
you can say there is a refractory period which keeps on increasing due to age.
True, sir.
Okay, so so the number of things that affect simulation, interest, excitement, etc. So that is one thing that already requires that, and he was, you can say, known to you. So how much open for whether he had some other relationships, etc. That is something that I would
Yes,
like
sir.
to explore.
Totally, I agree with all your points, sir. This discussion that you are putting forward, sir, about the compulsion to act, or maybe certain high libido that he was even in his premorbid self that was there, risk-taking behavior. We had discussed this. What the discussion came out was that in some case, in some persons, there might be a normal variant of high libido, which might result in this type of behaviors. Actually, whenever you hear this history, we think that he was having a very high restricting behavior. But then again, when he asked in details, he would cover up everything. He would not have such things that will someone find out. Actually, the wife found out through some very hearsay evidences, which were in a small town it happens. Now the thing is whether this was a compulsion to act a higher libido or just a normal variant of high libido, that was again huh, it was not a culture where this is very much accepted. Obviously, in the northern part, in the Haryana, and also he was not in an urban society. He was mostly in a rural society. Yeah, that was one thing that we can obviously discuss more about. Actually, ma'am, I had asked this thing whether he felt remorse or something with that. He told that he was feeling some kind of remorse when the child was when the child came into his life. He was feeling some kind of remorse. But then again, before that, when the wife was pregnant, he told that I was totally carried away, and then this girl, this female colleague, she, according to him, she was the one who approached him. She had an husband who was staying away, and she didn't have any company, so I was giving him company. So all these things, that's what he told. The remorse I found only after the child was born. He was accepting. Now, how much is he speaking with ingenuity, with genuineness, that needs to be looked into. So in these cases, there is I had spoken to the patient around 10 times, maybe 10 sessions I had taken after this thing also, after this presentation also. But then again, same things he comes up with. We cannot force the patient. Obviously, it's our staff. We can force them to come with the wife. Okay, but then these things have to be taken into the picture. At least he told me, but because first he went to the consult and he told nothing to the consult. He told nothing, absolutely nothing. With me, I had sat with him for maybe every time I used to sit with him for 1.5 to 2 hours, and he told me about these things. Sometimes you find patients exaggerating also. I had one patient who was telling that I take a bunch of Viagra every time, and he was telling he had relationships in IIT, Roorkee, and all. Every girl used to come. They used to pay money to him for that, and he used to take Viagra, and now his penis is totally dislodged, and even Viagra doesn't work. So he was taking Viagra not for any inadequacy. He was taking Viagra for increased sexual adequacy for 5 to 6 hours of work. So these type of patients also do come. Then he didn't follow up. Maybe he was some personality trait. But this, according to him, the personality evaluation was totally like all right. But then again, we have to take the family's history into consideration. I accept that the history corroboration is totally required. I can't go without that, because I have myself faced issues without corroboration. Like actually, ma'am, this detailed history taking of sexual history, I actually, the first format I had seen was in IBAS. IBAS, they have this 16 to 20 page of history taking for sexual history. So I've taken it from there, and there was all these things, whatever it was, attributes, what is likings, preferences, everything. Because people have sexual perversion, people have everything. But if someone is attached to a certain attribute more than what it should be, then we can also tell that. So these things I had taken from that, and this was actually a bit illustrative.
That was very important. Even if that was like my personal experiences, my patients will not give some detailed history. Because our culture is not like the Western culture that a doctor is a doctor. We always see the doctor of the doctor.
Yes.
Are you comfortable with male gynecology? No. So that's the thing. So I don't think it is possible for me even with record to get some detailed history.
It takes time. It takes a lot of time, and because he was not only a patient, he was our staff. It was very difficult to probe the questions, to say, because he was also very key. Should I tell something to anyone? That he was also very about that fact. Maybe he was undermining, maybe he was minimizing. I never know, because we had this system of feedback from others. Like for nursing staff, we had to give feedback from our side. For hours, they used to take feedback from nursing staff, behavior and all this. These we would not take, but still, people might think that this might have an effect. Yes. So that is there. So now, how much he was talking truly, that is something we have to go with. But then again, we cannot deny the patient was having some improvement, the PD5 inhibitors. But we cannot deny the patient of some treatment. And it was very low dose thing was used. After that, after 3 or 4 such follow-ups, he didn't follow up me again. Nothing. Actually, this is some part that we do not go through in our curriculum, in the PG course also. Generally, we do not take such a detailed history in the PG.
I would like in this case,
Yes.
For some common pathology, vascular.
Yes, yes,
So that I think
would be needed.
two things.
Totally agreed.
Second thing is that, say, in such cases, people either underreport their problem, also within like known for the person, or they try to exaggerate their performance.
Yes,
Okay.
yes, sir.
So that is one thing. For example, I find it in the history part that he was almost daily having
Yes,
physical
yes, yes.
with
Almost daily. Yes, that's what you do.
That in case of extrametal also you would have. And so that is one thing that I don't know what. So
This.
whether it was compulsion or it was just going to have every day. Okay. And what was it? Say, what was this idea about sexuality? Right? The refractory period, how it.
Sir, I had asked most of these things, and I had gone about how he performs his sexual act. So again, that I had described here, the foreplay part, everything. What leads to a proper stimuli? What leads to whether it is an emotional thing, whether it is from where does he derive his libido from? So for him, it was mostly a physical attribute that would be there. So it was.
Less feasible that he's carrying on extrametal relationship where he's having almost daily intercourse with 15 to 20 minutes of foreplay and so
true.
That is
Very true, sir.
A little bit difficult to. I was going to detail into that.
No, I had tried, sir. Even the same person had arisen. I had tried. He was so confident in telling that yes, I used to do that, and he would give me enough examples, and he would tell me. Now, whether he's telling me so adequately would force me to believe that it is exaggeration, or whether it is a good storytelling, or whether it was true, is very difficult for the therapist.
One is that, say, need. Okay. There is a libido, there is desire, and then there is the. For some people, it is not that need only that builds up, but it is rather it becomes a habit. Okay. Daily you perform this before you go to sleep. It becomes a habit. Not there is no intimacy involved. It is just an act that you perform. Okay. And then also it is that seeking pharmacological intervention. So whether he had earlier also thought like that.
No, sir, he had not reported any
nursing officer.
Yeah.
Okay.
He did not report in. Yeah. So I had asked whether he used to increase his already normal performance, wanted to increase. Well, sir, it was not. Usually happens with medical professionals too. But so
in this case, like kind of history very exaggerated, underreported, rapport difficult to establish. What are the like for example, for other areas we have like somebody having decreased appetite, somebody having decreased sleep. We have some fixed parameters. Suppose somebody is sleeping 4 to 5 hours a day, and we said it is daytime functional. So we can say you don't need to increase your sleep time. If you're a short sleeper, true. So with this, right? So how do you go ahead with this kind of regarding, you can say, sexual disorders? So that is one thing.
Sir, one more thing, like when we are having discussion, we also went back to our own ancient scriptures. that our in our ancient scriptures the sexual potency of individual are divided in both males and females according to animals like horse, elephant, and this mule. And in females it was rabbit, deer, and mare. So all speaking of these things, it can range from a huge to low. So whenever there is a mismatch between the partner, it might result in certain. This is just a corollary that I am drawing. It might result in these types of problems, or maybe these types of complaints, and the person might look into other avenues for his satisfying his sexual requirements, which might be very different from the requirements of the partner. So now, sir, because he had interpersonal relationship distress only once, as per him, and did not have any other dysfunction excepting this one that he is having now. It was very difficult for us to commit on any addiction or any increased other than the normal variant of increase. It was very difficult for us to term it as an pathological increase of the libido in the premorbid circumstances. Because even premaritally he used to have such, although not regularly, but still he was having a good amount of intercourse. So that way it was a bit complex.
So like organic disorder start from the beginning. Organic disorder it starts little long. Initial part is okay, is having good direction, and something can come up if the other factors are within normal. So from the history, somebody is having a good performance and it starts developing problems. So you look for organic problems. Psychogenic, it can vary. Okay. The part of the situation. So you will say many times like after child is born, the child is there. That the previous is a little bit less. There is a decrease in performance due to anxiety. Second, guilt sometimes can decrease that. So all these factors like that he was he felt guilty afterwards after the child was born.
Some guilt was there.
So
Yes.
How does that perform? How does that affect his, so,
but still he did not stop it.
And the participation is of the partner. So how feeling is the wife? How after knowing that the husband was in an extramarital relationship, what amends has he done?
Yes.
Okay, what is the relationship? What
Yes.
is her participation? Because she just participating for the sake of it. So that may be cause of decrease in the excitement, right?
True. But then again, sir, why I also harped on this question. But the thing is that even with the extramarital things afterwards, he was not having a good, very good sexual reaction.
That guilt part.
That guilt part can affect.
That also, like he already has this one. So earlier on, what he has the treatment, whatever he was doing. So that is that fear, something is stupid.
Had there been that guilt, sir, you would have looked out for partners even now. In AIMS education, you look out for partners.
There is a conflict.
Exactly, sir. There are some points leading towards psychogenic origin and some points leading towards an organic origin. So I found it very.
There's a drive in that person who has a high libido, natural, people say normal, whatever, and he's not getting avenues. Okay, he has disturbed the personal relationship, extramarital, he's trying at that. In conflict that this is happening. Right?
Maybe. Totally, total agreement with this thought. I tried. He was like, whenever I took such a long history, he did not expect me to take such a long history and query about attributes and everything. He was like looking at me with suspicion. Why he is taking such a long history and
he was just looking for a quick fix. That I just give me a pill.
Exactly.
I want to go okay. So.
And after giving the pill, he was satisfied. He was. Sir, yes, that is what my first thought was there because of the sleep problems. I was trying to corroborate and I was trying to make a case report actually, whether this is leading to that. But however hard I tried, I could not find a correlation because even after the RLS syndrome improved significantly with the improvement in sleep, the sexual complaints remained mostly as it is. So there was no such significant. May I be?
One hypothesis that he had harness surgery also.
Yes, sir.
And with the sexual activity, resolution, relaxation, he was able to maybe his symptoms decrease a bit. And that is why if he does not get that performance,
this hypothesis can be made.
decrease.
Sir, I tried to actually hypothesize with the dopamine part. Even RLS also is influenced by dopamine, and the sexual activity is also influenced by the same. But then I could not find good literature. Only with obstructive sleep apnea there has been good literature. But he had no obstructive sleep apnea. I tried. This BMI is also okay. He was a fit and fine guy. He was a tall, fit guy. Fit and fine guy, and with a good diet and everything. And he was this I tried vehemently for this to be a case report, but totally could not make it a case. I made a case presentation then. So, but quite a good case. Gave me a good bit of learning, because other cases are very simple. This was a case which I was not able to find certain things. Like I told you, ma'am, that whenever corroboration was present, that person found out to be a D with psychosis, depression with psychosis. He was looking totally as if a sexually inadequate patient. But then when the wife came, total D with psychosis, she tells that every three or four episodes he had, every time he has this episode, he complains of sexual inadequacy. And he actually tries to perform more, thinking that I am having affair with someone else. And he's totally okay now. For the last 2 years, I'm following up, totally okay. So corroboration is very important. And there are other cases who are very simple in nature. Find out the organic cause, do a USG, phenyl Doppler. And one patient that actually I was also very frightened. I had done around recommended around 20 to 25 phenyl Doppler cases. One had come with priapism. And as so in the night 3 p.m. he called me. He was coming from, I think, Raiwala or somewhere or Duiwala. No, I think Duiwala. He came at 3 p.m. in the night. That was mostly because of the radiology guy. They gave him the injection. Didn't follow after 3 hours. They have to follow after 2 to 3 hours, whether it is subsiding or not. The whole night he was having that injection, and he had to. Urology guys gave a good scolding. They took out the blood. He was already having some erectile dysfunction. He had total erectile dysfunction. And 3 months after he told that I'll file a case, everything he told, I tried to counsel as hard as possible. The radiology guys did not even talk to them. They don't talk. They just go into their room, AC rooms, and they don't talk. Mostly me, I tried to counsel the patient. He is in good follow-up with me, and he is having some erection now, so he is happy that it has not resulted in such, because when we drain the blood, all the compartments are very damaged compartment compartment divisions. So it might result in a permanent ED. We are very wary about giving USG Doppler to counsel everyone.
She was expecting him of erectile dysfunction, and to prove her wrong, he had to undergo this.
Yes, it's very.
And he was not counted properly. He was in Bengal.
Okay. मैम रेडियो के डॉक्टर्स बहुत टाइम नहीं बोलते, प्राइवेट सेंटर बहुत हम लोग, मैंने तो बोला था उसको, लेकिन रेडियो के डॉक्टर्स ने बिल्कुल नहीं बोला, और 2 आवर्स बाद फॉलो अप करना पड़ता है पेशेंट, ये उसको बिठाना होता है 2 घंटे, तो थोड़ा सा दिक्कत वाला चीज है. So I would like, sir, with your permission, I would like to tell the judge that sometimes in some cases you might take a bit of more sexual history than what you take.
Like sleep also.
It is very objective. The sleep history is very objective. Bedtime, wake time, sleep onset, latency. It is very objective. It doesn't have much subjective parts. So you can take it easily. Exactly. For young patients, it is a great motivating factor. For young patients, this sexual inadequacy will be there. For old patients, it will be different. The physical disorders will be a motivating factor. Young patients, we have used it. Thank you. There's a whole lot of treatment, ma'am.